Our expert speaker today is Dr. Gregg Werner, an interventional radiologist with Meritas Health. He will discuss different facets of interventional radiology, commonly referred to as IR. He will touch on various procedures, what to expect before, during, and after, and how most patients find their way to an IR specialist. Dr. Werner is board certified by the American Board of Radiology. He earned his medical degree from the University of Missouri-Columbia. He completed his residency in interventional radiology and diagnostic radiology at the University of Kansas. Dr. Werner specializes in vascular interventions and interventional oncology, such as the treatment of complex cancers with ablations and intra-arterial embolizations. If you have any questions about our topic today, please submit your questions using the Q&A feature below. We will respond to them at the end of the presentation. And now, please join me in welcoming Dr. Werner.
Hi, good morning. Like he said, I'm Dr. Werner, and I'm just going to give you a little bit of a presentation about some of the kind of areas of our field and what you could expect if you were to ever need to be a patient of ours. So starting out, just kind of the broad strokes of what is interventional radiology. And so it may be a term that people have kind of heard every now and then, but essentially it's a part of the radiology field that is a subspecialty area that's focused on the procedural side of radiology, where we do a wide variety of procedures that are image guided. And so essentially, we kind of interact with all of the other specialties, and we kind of function as both some of the more straightforward sides of procedures, as well as helping problem solve more complicated problems that need a couple specialties involved to figure out what the best plan is. So is it new? It's not particularly new. It's been around for several decades, and it's kind of evolved over time from being kind of like a lot of medicine, where a little bit more broad at one point in people's careers, where physicians did a little bit of everything, in decades past. And more recently, it's become increasingly specialized, where, especially in the last 10 or 15 years, it's kind of becoming more and more involved. And so it's become, more focused on fellowship-trained folks performing a lot of these things, and moved away from kind of the older model that existed. And so I'm one of the physicians that specialize in these type of procedures. So how is it different from surgery? There's a lot of similarities and there's a few differences. So the similarities are a procedure is being done, something is being changed, either placed or just kind of blood flow blocked, all kinds of differences that we can make in the body, similar to surgery. But the differences, typically, our process for making those changes are by traveling through systems in your body, either veins, arteries, or other systems, and getting to the location that we need to work on in that way, and then fixing it from that route. And so because of that, our incisions are very small, typically, compared to a lot of surgical incisions. And so that requires less recovery time and less stress just in general on a person undergoing a type of procedure like this. In terms of how it impacts patients, one of the ways that people get to us would be they go to a surgeon for whatever beforehand, and that surgeon says, I don't know that you are a great candidate for this surgical option that I have, but I think you could go for a less invasive option that you would tolerate better. That's one of the routes that people get to us. And so it's kind of like I alluded to earlier, it's a combined approach between us and other specialties deciding, what the best route is along with the patient, and kind of shared decision-making in that regard. Part of developing the interventional radiology program at North Kansas City Hospital allows us to keep these kind of procedures at home in this hospital. and we're able to kind of streamline the flow for patients, where instead of sending the patient to a different location and having to transfer all of their medical records there, we have all that access to that here. We can do all of the procedure here, the clinic visits if need be, and get everything done in-house, which allows faster treatment for whatever the patient's issue is. There's a wide variety of interventional radiology procedures. I just kind of made this list that is a kind of good ballpark for all of the types of things that we are involved in. The list is certainly longer than this, but it's a good reference for a ballpark idea of what all we have to offer patients at this institution now. So who is involved in interventional radiology care? So it's a combination of myself kind of helping orchestrate what we need to do and kind of the timelines that need to be involved after meeting with the patient and kind of making the decisions with them and their other physicians involved. And then we have a large team that supports us as well. Our transportation team helps get patients from point A to point B. We have our clinical team that works with us as well, nurses that both work in pre-procedure, post-procedure, during the procedure, and then we have our technologists that work with myself during procedures, performing whatever we are doing at the time. So how do we work with others? We kind of have talked a little bit about how a lot of our approach is a collaborative approach with other specialties, especially for more complicated issues, a lot of those including things that are oncology related, where there's a multitude of options that can be done, but it's kind of group selecting what is the best option for this patient in this exact scenario. And so we're involved with those decisions, and we also are involved in doing a wide variety of procedures that the referring provider knows what they want done. We don't necessarily need to have our input, and they can just tell us this is exactly what we want, and that's another route that we go about doing procedures as well. I think the biggest thing is we're largely kind of a problem-solving specialty where we kind of work in a lot of arenas. So if somebody doesn't have a great option for how they could potentially fix something, they'll reach out to us and see if we have any other options that they may not be able to do themselves. So the pathways patients come to us, there's a little bit of a variety, but most of the time it's a physician knows that we have a service that a specific patient of theirs needs, and they refer them to us so that we can either see them in clinic and decide with the patient what procedure they should have, or they already know what they should have and we can perform the procedure that route. We do have a clinic that we see patients in, and so if we have to go that route, we're happy to see people and decide with them what needs to be done. And then occasionally patients can directly refer themselves to us, and if we get those requests, it just kind of depends if we have something to offer in that scenario, or if we don't, we can certainly point them in the right direction of who they should see. So in preparation for an IR procedure, there's a couple of things to keep in mind. One of them is if we're giving sedation. So sedation for us means making somebody a little bit sleepy and forgetful, and so then we don't want people to eat after midnight the night before so that we can give them that kind of relaxing medication during the procedure. Some of our procedures, it matters if somebody's on blood thinner or not as to whether or not we would do the procedure. So depending on the blood thinner, sometimes we have people not take that for several days beforehand. That's largely the preparation portion of these procedures for our area. What to expect? So a lot of it depends on the specific procedure. So it's kind of the details are mostly dependent on what are we going to be doing for you that day, but the options essentially for how, for our sedation options include general anesthesia, which most people have heard of. It's where you're put entirely to sleep by our anesthesia team. Some of our procedures use that. It's more uncommon in our area than, say, the surgical area. We do a lot of moderate sedation, which kind of like I spoke about earlier. It's where you're kind of sleepy and forgetful, and a lot of times it's just kind of a little bit loopy is how people would describe themselves for that. And then there's local anesthesia, where it's just a local numbing that we numb the area that we're going to be working in, and patients don't really have feeling in that area anymore, but you're wide awake. So those are kind of the general options for that. Aftercare for an IR procedure, again, it's very dependent on what procedure you had done. A lot of our procedures, there's no particular restrictions afterwards. It's kind of, you go back to your normal life. The most frequent restriction we have for people is wherever we made our incision, we don't want them to submerge that in underwater until it completely heals over, which is usually pretty brisk at a week or less. And then some procedures, if we have to leave a drain in place, for instance, there's extra care that comes with those, but those instructions are all kind of both written, and our nurses go through them with patients after the procedure, so they kind of have the details about that. Typically, there's a little bit of pain at whatever procedure site we worked on, but it's typically a very short-term thing for a couple of days, and it gets better with a little bit of time. So we'll kind of go into some pictures where you can kind of see the images that I use during procedures to visualize what I'm doing and where I'm working at, essentially. And so if you look at the left side of the screen, you can see a person's spine, kind of if you're looking at them from the side. And so it's kind of the middle picture there shows the very dark needle is going into the bone, and that is basically what I'm using to access into that bone. And this is the kyphoplasty type procedure, where on the right image you can see there's kind of dark stuff that's filling up the bone in that area, and the dark stuff goes in as a fluid and becomes a solid, and it kind of operates like cement. And so as that fills that space, that's the cement going in and hardening that bone, and that's kind of one of the ways that you can fix this type of injury, which is a fracture in that bone. And so that's that part. That's a pretty common thing as well. So this, the picture in the top left, a lot of people spend a lot of years training to be able to look at these things, but the guideline I'd give you while looking at it is a lot of radiology involves symmetry. And so if you look at the picture, you can see the top part of the picture is kind of the front of a person's neck, and you can see the two sides look very different. And so the side on the picture's right, which is actually the patient's left, is quite a bit larger, and there's a lesion associated with that area. And if you look at the picture in the bottom right, that's a picture of me with an ultrasound machine showing the needle that I have entering into the same mass that you see in that CT scan on the top left picture, and taking a piece of it so that our pathologists can give them the details of what is this lesion and how are we going to treat it. So this is dynamic images, and if you look at these are kind of the images I take whenever I'm working in the veins, arteries, a couple other areas. But on the left, you can see is the initial picture that I took, where what you should be seeing is that the dark material is contrast that I put in the veins, and so it should flow rapidly back to the heart. That's what you want to see, but when you see on the left picture, it fills all kinds of other veins, and it should have just a direct path back to the heart that it rapidly travels through. And so the picture on the right then is after I have fixed this vein, and I've basically kind of reconnected the parts that had been previously blocked off, you can see as that contrast goes in, it rapidly goes up, and it's basically just traveling back to the heart much faster than it was initially. And so this is commonly thought of as a deep vein thrombosis, and it's a treatable condition where you can fix it in this way and relieve people's symptoms much faster. So this is something we do pretty much every day. This is a biopsy, and for this person, these are 2 CT scans, and on the left one you can see kind of symmetry at play again here. On the left part of the picture, you can see there's little kind of like rounded bright white nodule in that sea of black, and so that little nodule shouldn't be there. And so we wanted to find out, our pulmonary colleagues wanted to find out, what is that? And so the way that we do that is, if you look at the picture on the right, you'll see I have placed under CT guidance a needle into that little nodule, and I'm in the process of taking another little piece of it so that our pathology folks can take a look at the cells, decide what it is, and help both the pulmonary and oncology folks decide what needs to be done. And so we talked about it a little bit earlier, but how do you all get connected to an IR specialist? Well, the best route is to talk to your physician that is seeing you already, be that family practice, oncology, any route. And most of the time they will know if you have something that would be kind of in our realm. If they're uncertain, we're happy to meet, talk to them, or meet with you and determine if it's something that we are capable of helping you with. If you want to go a different route, you can contact our office directly as well. We're happy to review whatever records we can and any imaging that you have, and determine what we can do to help, if anything. And if we can't, kind of like I said earlier, we're always happy to refer to somebody that we do feel like could help. And that's a process we can do if we need to. Thank you very much for your time.
Well, that was fascinating. We have a few minutes for questions from our audience. There's a chat function. You can post a question. So let's see what the audience has for us. Okay, here's a question. Why has interventional radiology been able to grow so quickly in the 21st century?
Well, a big part of that is it's a very technology driven field. And so there's not only new procedures being kind of made every now and then that are being added to kind of our arsenal, but the technology and being able to image these parts of people's body, and the technology of going into like the devices that we use to travel through the vessels to get where we need to go, have improved remarkably over the last 10 to 20 years. And so we're able to do much more than we have been in the past. And so that's been a big area of how we've grown like we have.
So here's another question from the audience. I've heard that interventional radiology can be more effective than traditional surgery. Can you explain how that can be?
Well, I think it kind of depends what you mean by effective. So, for effective, surgery is very effective, but it kind of depends. For people who couldn't have the surgical option and could probably tolerate the interventional radiology option, then it's very effective, because that's a patient that otherwise wouldn't have been able to have any fix to their problem. I would say, generally speaking, surgery and interventional radiology have similar effectiveness in a lot of areas, but it just kind of depends on the patient specifically and their issue at hand as to which one's a better option for them.
Okay, this is a bit of a personal question from the audience. How many IR procedures do you typically perform in a week?
It kind of varies. A lot of it depends on how many bigger, kind of longer procedures we have set up, but I would say anywhere between like 60 and 100 procedures a week would probably be our average.
That's a lot. That really speaks to the variety of things that IR provides. So what is your best IR success story? Just one story where you hit it out of the park.
I think one of the most memorable ones for me was there was a lady who was in her 90s who was had on her scans, she had a couple of arteries that had been blocked off, and she wasn't really able to eat without a lot of very intense abdominal pain. And I went in and reopened 2 of her arteries to be able to get blood flow back to her intestines, essentially, so she was able to eat again without having horrible pain.
That's remarkable. So if you could look into the future, 5 years, 10 years, 20 years, what does IR look like looking out into the future?
It's a growing field. Our area is constantly expanding. People are finding new ways to fix things that are less invasive, and the technology is just getting better and better. So I fully expect that our field's just going to continue to grow. We're going to add things every year that we can do that previously we couldn't, and I think kind of the sky's the limit.
Well, that's great. Well, thank you very much, Dr. Werner. We hope this presentation was informative and helpful. Looking ahead, I'd like to invite you to join us on September 21st for Steady Your Stride, an event that helps seniors assess their potential risks and prevent falls. To learn more about it and to register, visit our website at nkch.org/steady. Again, thank you for joining us, and have a good afternoon.